Hello, ladies. Ozempic, Wegovy, Mounjaro, Zepbound. These names are everywhere right now. They're in your social media, on the news, in conversations at the book club, but there's a lot of noise around them hype, backlash, confusion, and some genuinely extraordinary science that gets lost in celebrity headlines. Today, we're going to get through all of it. What are these medications? How do they work? Are they safe? And here's the part that barely makes the news. What are they doing to our health beyond weight loss? Buckle up, this one is fascinating. GLP-1 stands for glucagon-like peptide 1. It's a hormone that our body naturally makes. It's secreted by cells in our small intestine and our colon in response to eating. And it does several things. It tells our pancreas to release insulin. It slows down the emptying of our stomach so we feel full longer. And it signals our brain that we've had enough food. It's part of our natural appetite regulation system. GLP-1 receptor agonists are the medications designed to mimic and amplify this hormone. They bind to the same receptors, but because they were engineered to resist the enzyme that breaks down our natural GLP-1, they last much longer. They last days instead of just minutes. Now let's name names. Semaglutide is the active ingredient in Ozempic. It was approved for type 2 diabetes, and Wegovy was approved for chronic weight management. It's a weekly injection. In clinical trials, participants on semaglutide lost an average of 15% of their body weight over 68 weeks. And then there's Tirzepatide. That one is sold as Mounjaro for diabetes and Zepbound for weight management, and it was approved in November 2023. This one's different. It's a dual agonist, meaning it activates the GLP-1 receptors and GIP receptors. GIP stands for glucose-dependent insulinotropic polypeptide, which is another gut hormone involved in metabolism. The dual action appears to turbocharge the effect. Now, how well do they work in menopause specifically? Great question. And until recently, we didn't have a great answer. There was a lot of concern that the hormonal environment of menopause might blunt these drugs' effects. But a 2025 post hoc analysis published in the journal Obesity, led by endocrinologists at the New York Presbyterian and Weill Cornell Medicine, looked at tirzepatide's effects across all reproductive stages of women's lives. And their conclusion was that tirzepatide was equally effective for perimenopausal, postmenopausal, and premenopausal women. These findings are also expected to apply to other GLP-1 agonists. In short, menopause doesn't appear to diminish these medications' power. 2025 RAND data shows women ages 50 to 64 have the highest GLP-1 use in the US, with about 20% reporting either current or past use. Women aged 30 to 49 were more than twice as likely as men of the same age to be using these medications. Now, let's be real about side effects, because this is where a lot of people stop listening to their doctors or start listening to the wrong things online. The most common side effects are gastrointestinal: nausea, vomiting, diarrhea, or constipation. These are most pronounced when starting the medication and when doses are increased. The standard protocol then is to start at a low dose and gradually increase over months, which significantly reduces these effects for most people. Less common side effects but more serious risks include a possible increased risk of pancreatitis, and there is a black box warning about a type of thyroid tumor called medullary thyroid carcinoma, though this risk comes only from animal studies, and the real-world human risk remains unclear. People with a personal or family history of that tumor type or multiple endocrine neoplasia syndrome type 2 should not use these medications. There's also a phenomenon that's gotten attention: the Ozempic face, the loss of facial fat that can happen with rapid weight loss on these drugs. And muscle mass loss is a real concern, which is why resistance training and adequate protein intake are considered essential companions to these medications, not optional add-ons. One thing I think is very important to state is that the muscle loss happens with any form of weight loss, whether you are on GLP-1 medications, whether you lose weight through Weight Watchers, whether you have bariatric surgery. So it is not characteristic of only those medications. Okay, this is the part that I find genuinely mind expanding because these drugs are turning out to be far more than just weight loss medications. Now, let's go organ by organ. The heart, the SELECT trial, a major cardiovascular outcomes trial, demonstrated that semaglutide reduced the risk of major cardiovascular events by 20%, including heart attacks, strokes, and cardiovascular death, even in people without diabetes. The European Medicines Agency approved semaglutide in September 2025 specifically as a stroke management therapy. That's the first time a GLP-1 drug received this designation. GLP-1 receptors are found throughout the cardiovascular system, and when they are activated, they appear to reduce arterial stiffness, to reduce blood pressure, to reduce inflammation, and they improve vascular function independently of weight loss. A meta analysis in the Lancet Diabetes and Endocrinology in 2024 found GLP-1 receptor agonists specifically reduce major adverse cardiovascular events, or MACE, kidney failure, and clinically important kidney events. So, what about the kidneys? The FLOW trial found that semaglutide reduced the risk of kidney related complications by 24% in people with diabetes and chronic kidney disease compared to placebo. It is the first major study to directly assess GLP-1 effects on kidney disease, and the results were strong enough that the trial was stopped early because the benefit was so clear. Researchers believe that the mechanism involves reduced kidney inflammation and improved sodium handling. What about the brain? Well, this is perhaps the most surprising frontier. GLP-1 receptors exist in the brain, and these medications appeared across the blood-brain barrier. Preclinical studies show that they reduce neuroinflammation, they protect neurons, and they improve synaptic function. A pooled analysis of 3 major cardiovascular trials involving over 15,000 patients found that those on liraglutide or semaglutide had a hazard ratio of 0.47 for subsequent dementia diagnosis, meaning roughly half the dementia risk compared to those not on the drug. Trials are now underway for Parkinson's disease and Alzheimer's. GLP-1 drugs also appear to reduce addictive behaviors. Researchers are investigating their potential in alcohol use disorder, smoking cessation, and even opioid addiction. In 2025, Harvard Health reported that GLP-1 users had a 10 to 20% reduction in heart failure, cardiac arrest, lung failure, pneumonia, Alzheimer's disease compared to those who were not on GLP-1s. What about the liver and inflammation? There's also strong evidence for benefits in fatty liver disease, which is now called metabolic dysfunction associated steatotic liver disease, and sleep apnea. And the anti-inflammatory effects are systemic. These medications appear to reduce the chronic low-grade inflammation that underlies so many of the diseases we associate with midlife and aging. Researchers are only beginning to understand the full scope of what GLP-1 receptors do when activated in tissues throughout the body. A few things that matter practically. These are injectable medications. They're given weekly, though oral semaglutide does exist in lower doses. Cost is a real barrier. Without insurance, these drugs can run from around $500 to $1,300 a month. Coverage varies widely. They're not approved specifically for menopause, but they are prescribed for weight management in menopausal women as part of a whole obesity treatment. And here's something critical. When people stop taking these medications, much of the weight comes back, primarily as fat with less muscle than we had before. So the conversation with your doctor needs to include a long-term plan. These are not short-term fixes for most people. They're chronic disease medications similar to how we treat blood pressure. Here's where I land after all of this research. We are in the early days of understanding how powerful these medications are. The weight loss headlines are real, but they may end up being the least interesting thing about GLP-1 drugs. For women in the menopausal transition who face a perfect storm of hormonal, metabolic, and cardiovascular changes, these tools combine thoughtfully with hormone therapy, resistance training, eating and a protein focused diet represent a genuinely new frontier in midlife health. Talk to a menopause informed clinician. Bring the research. Ask about all your options. You deserve a conversation that reflects 2026 science, not 2002 fears. Thank you so much for being here for this series. Share it with someone who needs it because chances are you know someone who does.